Yeah, bladder preservation. I think you've seen Lenny and Dan's talks have shown that bladder has become sexy again. I'm going to show you how it's really sexy now. So, in honor of the last day of the Olympics and the Greek origins, the Titanomachy, the Titans versus the Olympian gods, it was a 10-year war between the old guard, the Titans, and the new guard led by Zeus. Guess who won and took over the cosmos? So there's been a big paradigm shift in oncology towards organ conservation. We all know that there is morbidity with a radical cystectomy. It's an excellent operation. Many patients do extremely well, but it can be life-altering and physiologically challenging. Cystectomy is also not being performed in 50% of patients nationally, especially in the age group that we are concerned about for muscle-invasive disease. And trimodality therapy really remains very much a surgical approach. The maximal TUR, cystoscopic assessment, lifelong cystoscopic surveillance in those that have done well, and 10 to 15% of the time patients may need a salvage cystectomy. In terms of the long-term outcomes of trimodality therapy, complete response rates these days approach 90% to chemoradiation. 5-year disease-specific survival rates about 85%. Less than 15% of patients need salvage cystectomies. Yes, selection is important. The factors that I've highlighted here are associated with outcomes, but similarly, most of them are associated with outcomes after cystectomy. But there are some patients that are not good trimodality candidates. Those that have T3b, T4 disease where there's a lot of residual tumor, the presence of significant bilateral hydro, large tumor burden, extensive diffuse multifocal CIS, tumor in a bladder diverticulum, upper tract involvement, prostatic involvement. These are situations certainly where I'm gearing patients towards neoadjuvant chemo and cystectomy. But about 30%, I would estimate, of muscle-invasive disease would be good candidates for trimodality therapy, and I'll show you some data about that. I'm showing you here an MRI. It's showing muscle-invasive disease in this diverticulum, in the stalk of the diverticulum. This is not a great candidate. You're not going to be able to achieve a maximal resection of that tumor. I also show that because MRI has improved soft tissue resolution compared to CT in bladder cancer, and it is way underutilized in staging. Muscle-invasive bladder cancer is a significantly clinically understaged disease. 45% of the time, T2, clinical T2, would become pathologic T3, T4 at time of cystectomy. So I think we should be using MRI more. There's the VIRAD system, similar to the PIRAD system. I won't get into the details of that. But basically, the most promising use of MRI is in the pre-TURBT setting. Best evidence is in muscle-invasive disease. It may also correlate with response to treatments such as chemoradiation. So how does trimodality therapy compare to cystectomy? There is no completed randomized controlled trial. I would argue this is the best available evidence. You can see I did this with colleagues from Toronto and USC, so Alex Zloda, surgeon, Sia Danishmand. He's probably the biggest cystectomist, and USC is probably the biggest cystectomy center in the US. So we put all our data together, did high-level statistical analyses. You can see that the inclusion was tumors had to be less than 7 centimeters. You could have a unilateral hydro, but not bilateral. You could have a little CIS with the tumor, but not multifocal diffuse. You can see that the matching was excellent here. Here is the average patient that was included in the analysis. And basically at, the 5-year metastasis-free survival rates were no different. And the regional failure-free survival rates were no different, as you can see. If we just looked at the patients that got cystectomy who also got NAC, given level 1 evidence supporting that, compared to TMT, there was no difference. And this speaks to the generalizability of the results. It didn't matter whether you had a cystectomy in Toronto or in LA, or received your chemoradiation in Toronto or Boston, there was no difference. And that applies to cancer-specific survival as well. And this is just a reality check. If you had T3, T4 disease, or you had hydro in the cystectomy patients, they did worse, just like they do worse with TMT. But there was no subgroup that did better with cystectomy compared to TMT. If you looked at those that had the unilateral hydro, the T3 patients that we had in the analyses, they, again, did similarly. And this is important. 13% got a salvage cystectomy. Like I told you, that rate's 10 to 15%. 20% are going to have non-muscle invasive recurrences over time, so you got to follow them cystoscopically lifelong. And here's that piece that I was talking about, the clinical understaging. Pathologically, you could see that there was a lot of upstaging of disease in the cystectomy cohort. The same would apply to the TMT cohort. And this was excellent surgery. Only 2.5% peri-RC mortality. That's in line with the Sloan Kettering data. 39 nodes removed, in median number of nodes removed. Positive margin rate was 1.1%. You couldn't get better surgery. The results weren't what they were because of bad surgery. So where is radiation going? There's a lot of advances. I would say big moves towards hypofractionated radiation, shorter courses, and the use of image-guided radiation. So a lot of stuff that Peter got into yesterday. There's studies from the UK, the RADAR trial, that used adaptive delivery, showing that you could go to higher doses without increased toxicity. There's also studies from the UK doing 6 gray times 6 over 6 weeks. So ultra hyperfractionation with adaptive planning showing very acceptable toxicity rates as well. So all of that has led to this. This is going to be the new big bladder-sparing trial. It's comparing 20 fractions to 5 fractions. Yes. Now, if what's one of the biggest limitations to getting bladder preservation therapy is financial toxicity given the duration of treatment and access to care. So if this actually can be pulled off and 5 fractions can be shown to be a viable option, I think it will open this treatment paradigm up to a lot of patients. So a lot of advances in systemic therapy. Concurrent chemo is needed. We know that from the BC 2001 trial. There's lots of active radiosensitizing drugs, lots of options for non-cisplatin candidates. And what about neoadjuvant chemo? To date, there hasn't been a proven benefit to that, but I think from Dan's talk, you can hear the excitement behind things like EV Pembro. It's going to move into earlier disease spaces. You can imagine that being given neoadjuvantly good responses than getting bladder-preserving chemo-RT. Long-term toxicity is good. It certainly does better on sexual quality of life than cystectomy, better informed decision-making, less concerns about appearance, less life interference from cancer or cancer treatment. And this is translated into quality gains as well in some decision analysis studies. Now, there are those 20 to 25% that have superficial recurrences. And what do you do with them? Well, you can treat them as you would otherwise with TURBT intravesical therapy, and they tend to do similarly well. And for those patients that need a salvage cystectomy, the 10 to 15%, they do just as well as those that didn't need a salvage cystectomy because they didn't have a muscle-invasive recurrence. That tells you that the salvage cystectomy remains curative in this population, is a very important part of the treatment paradigm. And the morbidity of a salvage cystectomy is acceptable. It's been compared, the salvage cystectomies against the primary cystectomies, a little more grade 3, grade 4, but overall acceptable morbidity in published series. So yes, TMT is supported by numerous guidelines. It's category 1 for stage 2 disease in NCCN and category 1 for stage 3A disease in NCCN. So it needs to be discussed with patients. And we might be expanding this. What about non-muscle invasive disease? So high-risk recurrent non-muscle invasive disease, having gone through multiple lines of intravesical therapy, salvage cystectomy is the next step. We have this paper that's just coming out in JCO showing an 88% free from cystectomy rate at 3 years with chemoradiation, and that's led to the development of this other trial in the National Cooperative Group setting, looking at RT plus Pembro versus chemo-RT in that type of population. In the last minute or so, just going towards biomarker-driven management of disease. A lot of work in this. There's a lot of selected biomarkers that have been looked at in Trimodality series. MRE11 is one of those that if you have high expression, you do better with chemoradiation, no different with cystectomy, so it might be predictive. ERCC2 mutations have been associated with better survival. Immune infiltration signatures are associated with improved outcomes. So that's telling you if you have an immune-activated subset of patients, they may do better with chemoradiation. That tells you that maybe we should be adding immunotherapy into this paradigm. And so that brings us to that relationship between radiation and the immune microenvironment. There's been an explosion of immunotherapy indications and FDA approvals, and Dan went through some of those. And again, adding, radiation has an interesting activating and suppressive effect on the immune system. So can you add immunotherapy to tip the balance towards an anti-tumor immune response? And this is the trial, SWOG NRG 1806, that looked at chemoradiation plus minus atezolizumab. And this is the largest ever accrued to trial in bladder preservation in the world. Actually, it was 485 patients that over accrued. The top accruer, Scott Delacroix, surgeon urologic surgeon from LSU, Louisiana, accrued 70 patients to this trial. He'd never done bladder preserving therapy before, and now he is actually the co-PI of those new trials that I showed you, the 20 versus 5 fraction and the non-muscle invasive study. Basically, adding immunotherapy seems to be safe in early safety analyses from that trial. There's also this Keynote 992 study, exact same study, but using pembro instead of atezo. And in conclusion, I think hopefully I've shown you that many patients are not getting curative treatment for muscle-invasive disease. TMT is supported by numerous guidelines. Survival can be comparable to radical cystectomy in the modern era. More than 85% of these patients are going to keep their bladders. Long-term quality of life is good. TMT is not a non-surgical treatment. A maximal TUR, salvage cystectomy are important components. Lots of opportunities to improve this, the staging of disease, the eligibility for radiation, the delivery of radiation, the systemic therapies, all to improve access, indications, and outcomes. And we need to validate those biomarkers prospectively. Ultimately, informed decision-making by the patient is key, so they have to be given options if they're candidates. And thank you very much.